Hello, my name is Dr. Dayna Long. I am a pediatrician at UCSF Benioff Children's Hospital in Oakland and the co-director of our Center for Child and Community Health. I am very pleased to talk to you about adverse childhood experiences and toxic stress, screening and intervention. The mission of ACEs Aware is to change and save lives by helping providers understand the importance of screening for ACEs and training providers to respond with trauma-informed care to mitigate the health impacts of toxic stress. During this core training, we have four main objectives. The first objective is to define ACEs and their prevalence, health disparities in data sets. We're going to talk about what is toxic stress physiology and the related impacts on health of toxic stress, and really think about those underlying biologic mechanisms. Our second objective is to identify how to introduce and integrate ACEs screening and toxic stress screening into healthcare clinics, making sure that we are aligned with the principles of trauma-informed care. Next, we will apply the ACEs and toxic stress risk algorithms for assessing toxic stress, which include a combination of screening for ACEs, identifying the presence and extent of ACE-associated health conditions and protective factors, in determining appropriately tailored treatment plans and follow-up, including referrals as indicated. And last, we will identify what are the payment requirements? How do we actually receive payment for administering ACEs screens as part of a toxic stress risk assessment? We are all familiar with this notion of ACEs. The term ACEs comes from the landmark study in 1998 that was conducted by the Center for Disease Control and Kaiser Permanente. The original ACEs study describes 10 categories of adversity in 3 domains of experiences or stressors that occurred prior to 18 years of life. So those 10 categories and 3 domains include abuse, that's physical, emotional, or sexual abuse, neglect, physical and emotional, and household challenges. And this is the broadest category. And it incorporates growing up with a household member who's incarcerated, having a caregiver who has mental illness, having substance abuse in the family, being separated from a parent secondary to divorce, or intimate partner violence. I do want to stress that these are what we refer to as the initial original 10 ACEs. For these ACEs, we do have large, robust population level data that really lets us know about the relative risk for health conditions. So for these traditional ACEs, we know, for instance, that an individual who has 4 or more ACEs, we know that the relative risk for having cardiovascular incidences like ischemic heart disease is 220%. That's not to say that there are additional stressors that are not correlated with toxic stress. There are. But when we refer to ACEs, we refer to these 3 domains and 10 categories of experiences. Both children and adults have impacts from toxic stress and the exposure to ACEs. For children, if they have experienced 1 or more ACE, they have higher odds for stomach aches, for asthma, for poor perceived health, and for decreased global executive functioning. If a child has 4 or more ACEs, they are 2 to 3 times more likely to have asthma and 33 times more likely to have learning and behavioral issues. We also see the impact of ACEs on adults, so that for adults who have experienced 4 or more ACEs prior to the age of 18, they are over 2 times more likely to have heart disease or cancer, 3 times more likely to have respiratory illnesses, over 4 times more likely to have depression, are more likely to have problematic drug use, are 37 times more likely to attempt suicide, and have 9 out of 10 of the leading causes of death in the United States if they have 4 or more ACEs. Within the state of California, our Department of Public Health Injury and Violence Prevention surveyed Californians. And what we found is that 62% of Californians have experienced at least one ACE, and 16% have experienced 4 or more. This data was from 2011 to 2017, and so this is pre-COVID data. So what are ACEs about, right? ACEs are about stress. And there really are 3 different types of stress. We can think of positive stress, tolerable stress, and toxic stress. And it's important to recognize that when we are talking about the accumulative risk of ACEs, we are referring to toxic stress that then is impacting the poor health outcomes. So let's dive a little bit deeper into these 3 different types of stress. Positive stress. We think of positive stress as there being brief activation of our stress responses. Brief elevation in heart rate, brief elevation in blood pressure, brief elevation in hormonal levels, cortisol, epinephrine, norepinephrine. And the stress is soon over, right? And you go back to a level of homeostasis. An example of positive stress is you have a test, it's the first day of school, you have a big presentation. Tolerable stress is time-limited stress that results in brief, but slightly longer than positive stress, increase in heart rate, blood pressure, and stress hormones. But you are in the confines of having safe, stable, buffering relationships and environments. That stress is temporary, and you go back to homeostasis. An example might be a big move, or unfortunately, the death of a grandparent. Through the buffering effects of caregivers and adults, you recover. Toxic stress is when buffering, safe, stable, nurturing caregivers and environments are absent and inadequate, and the stress is prolonged. You see this prolonged activation of our neuroendocrine and immune system that leads to long-term changes in our brain and our body. You have activation of a stress response that lacks the normal inhibitory feedback or the ability to turn the stress switch off, right? Which usually happens when you are couched within safe, stable buffering relationships. So this prolonged stress is unchecked and continues and can lead to stress-related diseases and cognitive impairment. Examples of toxic stress include abuse, neglect, household challenges. When we think about a buffer, we think about this notion of safe, stable, nurturing caregivers and environments. It's really important that we are actually able to define what we mean by safe, stable, and nurturing. These definitions come out of the Center for Disease Control, and let's walk through them briefly. Safety is the extent to which a child is free from fear and secure from physical or psychological harm within their social and their physical environment. Stability is about the degree of predictability and consistency. It's about routine in the child's social, emotional, and physical environment. And then nurturing is the extent to which a child's needs are met sensitively and consistently. Toxic stress can be defined as when you have high doses of accumulated adversity that are experienced during critical and sensitive periods of early life development prior to the age of 18, without having those buffering, those safe, stable, nurturing relationships and environments. Toxic stress leads to prolonged disruption of brain development, of our immune and hormonal systems, of genetic regulatory mechanisms. And this is what we refer to when we think about ACEs and the toxic stress physiology that it can trigger. One of the things about ACEs screening that's really important to recognize is that the purpose of ACEs screening is not to get a score, right? It's not to get a score, but it's more to identify children who are at risk for either having or developing this toxic stress physiology that then can lead to poor health. I want to make sure that everyone recognizes that children can be exposed to early life adversity, right? And then it's a balance between these protective factors, safe, stable nurturing, predisposing vulnerabilities that balance each other. And if this toxic stress accumulates, you can get dysregulation of your stress response with neuroendocrine, immune, and genetic regulatory disruption that can lead to health problems, both physical health problems as well as behavioral health problems. Starting in about 2014, a research team that included myself and my colleagues at the Center for Youth Wellness, as well as the UCSF School of Medicine, got together to start to think about how we can create a prospective pediatric ACEs screening tool in order to identify children early on in life in order to prevent, heal, and treat toxic stress. We also wanted to look at clinical indicators, biomarkers, and clinical diagnoses that are correlated with developing toxic stress physiology, and ultimately develop interventions that are evidence-based in order to respond and treat toxic stress. As a result of this research, we developed what we call the PEARL screen, right? So PEARL stands for Pediatric ACEs and Related Life Events Screener. When we were thinking about creating this screen, we wanted to make sure that we were true to the science. And so part one of the screen are the original 3 domains and 10 categories of ACEs. Recognizing that there are other stressors that can lead to toxic stress, we added a part 2. And that part 2 includes questions about food insecurity, housing instability, exposure to racism and discrimination, and bullying outside of the home, including violence. This is community violence as well as police violence. Part 2 of the PEARL screen screens for these other stressors which are thought to be associated with toxic stress. They are not ACEs. They are related life events. Some people might call them social determinants of health. I want to make it clear that social determinants of health, again, they are not ACEs, right? ACEs are those original 10 categories and 3 domains that were identified in that landmark study by the Center for Disease Control and Kaiser Permanente. Social determinants of health are these upstream factors or conditions in the environment in which people live, work, play, worship, and age that also affect a wide range of health, of functioning, of quality of life outcomes, of risk. These social determinants of health include education, employment, health systems, public safety, the social environment, and transportation. We do have very large population level data sets for the initial 10 ACEs, and we have strong associations between ACEs and toxic stress. We are getting there with these other social determinants of health, but yet we do not have the same type of large population studies with validated odds ratios for determinants of health. Hence, they are not considered ACEs. They weren't part of the original study. As I had mentioned, as part of the PEARLS tool, we ask questions about racism and discrimination. I will refer you to the American Academy of Pediatrics policy statement on racism that was published in 2019. Racism is defined as a system of structural opportunities and assigned value based on social interpretation for how someone looks, what we call race, that unfairly disadvantages some individuals and communities and unfairly disadvantages some over others, and ultimately straps the strength out of the entire society. Racism is a core determinant of health. It's linked to health disparities, it's linked to physical as well as mental health concerns, And racism is linked to biologic mechanisms that can cause dysregulation and toxic stress. When you look at the Pearl screen, you can see that there's a part 1 based upon the initial ACEs, and there's part 2, which are these related life events. At Children's Hospital in Oakland, we did a randomized controlled trial for very young children between the age of 0 up to the 12th birthday and asked caregivers to report on the ACEs as well as these related life events for their children. On this slide, you will see that the initial ACEs are the top of the slide, that dark black color, and the lower half of the slide are these related life events. What we found is that both ACEs and related life events are common. You can see the prevalence on this graph. You can look and see that almost 40% of our caregivers endorse that there are mental health concerns in the primary caregiver of the child. Over 30% of our children were exposed to domestic violence. 30% of our children had parents who were separated or divorced. In terms of the related life events, again, prevalence levels were high. A quarter of our children are exposed to violence in their neighborhoods. Almost 20% of our children are exposed to food insecurity and housing instability. And 15% of our children at a very young age are exposed to significant discrimination. We also created correlations between these related life events and the probability of having one initial ACE and then a second ACE. What the research showed is that there is a correlation between these related life events and the probability of exposure to ACEs. For instance, if a child lives in a neighborhood where there is violence, there is a 90% probability of them having one ACE and almost a 74% probability of having another ACE. These related life events are part 2 of the Pearl screen, and the initial ACEs were taken from part 1. We also created a Pearl screen for adolescents. There are 2 additional questions on the adolescent screen for part 2 than on the child screen. So those 2 additional questions are the last 2 questions that you see here. And so we ask adolescents if they themselves have ever been detained, arrested, or incarcerated, or if they have experienced verbal or physical abuse or threats from a romantic partner. If you are screening a patient and they are between the ages of 0 to 21, you can use the Pearl screen. If you are screening an adult, anyone 21 and above, you can use the initial ACEs questionnaire. And you see here, this is the initial ACEs questionnaire that's presented in a de-identified format. By de-identified, I mean that there's no item level response, that the patient is giving you in a composite or an aggregated score. So let's talk about that a little bit more. Let's talk about versions of the Pearls and ACEs screen and formats. There are 4 versions of the ACEs screen. There is the Pearl screen, and that is for children 0 through age 11 up till the 12th birthday. And then there's the teen version. There's the teen version that is based upon caregiver report, which is 12-year-olds up to 21, where a caregiver, such as a parent, will actually fill it out for the teen. And then there's a teen self-report, and the teen self-report is for teenagers over the age of 12 up until the 24th birthday, and they fill it out themselves. And then the last version is the adult ACEs screen. There are 3 formats of screening. There is the identified format. The identified format is an item level screen where each question that is positive will get marked by the patient. The de-identified is an aggregate or composite screen where you get a total score. And there's also a mashup screen. The mashup screen is where part 1 is de-identified, you get an aggregate total score, and part 2 is an identified screen. The screen also comes in 17 different languages. You can download all of them on the ACEs Aware website. And then you can distribute the screen through multiple modalities. You might use paper screen so that when a child comes in for a well check, you actually physically hand the screen to either the child or the parent, depending upon the age. Many clinics are building out the screens into their electronic medical records. For telehealth, some clinicians are doing screen shares so that the patient can fill it out during their visit, or they're uploading the screen to their website and patients can look at the screen on those websites. So who do you screen and what is the frequency of your screening? We recommend that you screen every single patient without selection bias, meaning that screening is universal, that it's not based upon perceived risk factors or presence or absence of symptomatology or illness. Medi-Cal is paying for ACEs screening based upon the following schedule. So if you are under the age of 21, you are permitted to screen your patients, your children, for ACEs annually. For adults between the age of 21 to 64, you can screen once in the lifetime of that adult and receive payments. The reason why we screen is because we want to be able to improve the efficiency and the efficacy of the healthcare system. We want to be able to support our patients, our families. We want to be able to encourage well-being. We want to be able to reduce healthcare costs from chronic illness. And we need to be able to have hard conversations in order to normalize trauma and reduce stigma and judgment. The National Academy of Science, Engineering, and Medicine recently adopted recommendations to screen for trauma and adversity early in life in order to increase the likelihood of early detection of toxic stress. This should include creating rapid response and referral systems that can quickly bring these protective factors, the buffers that we referred to bear when early life adversities are detected through the coordination of cross-sector expertise. The reason why we screen adults is because we want to be able to improve our treatment, our management of ACE-associated health conditions such as asthma, diabetes, hypertension, cancer. And we want to be able to prevent the vertical transmission of ACEs and toxic stress to the next generation. We want to be able to break the cycle of ACEs. We have to think about how we are actually screening and incorporating that into our standard of work in order to transform our standard of care, right? We need to create workflows, and those workflows include very detailed information that is a prototype that each clinic is then going to need to adapt to their own clinic, the uniqueness of what the name of that registration person is, or who that nurse is, or who that provider is. But there are key elements of these workflows that are common. We need to know who's going to administer the tool, how we encourage families, patients to complete it, how do we review and score the tool, what are the clinical treatment algorithms in order for us to think about how we can best respond to a positive screen, what's the follow-up plan, how do we document and track the screening and the response? And importantly, how do we bill? We're going to walk through each of these points now. This is the pediatric ACEs screening clinical workflow. Let's walk through it. Initially, a staff member, it might be a registration staff or a clinic staff, will review the patient record to determine what is the appropriate screen, based upon what language the family speaks, the age of the patient. They will make sure in a trauma-informed manner, such as making sure that the patient has privacy and a safe space, administer the screen to that patient or that parent. That patient or parent will complete the screen. It gets handed to the provider. The provider reviews the screen with the patient and the family. We will follow the appropriate risk assessment algorithms. We will score the screen. We document it in the electronic medical record. We bill. We create a treatment plan and a follow-up visit. And prior to the next visit, when we follow up with the family, we will again review what the ACE score was, review that treatment plan, and make sure that we continue to follow up with our families as needed. So once you get that screen, you will need to score it. We have created an ACEs toxic stress pediatric risk algorithm, and the screen itself is scored as being either low risk, intermediate risk, or high risk. A low risk screen is a screen that has a score of 0. If you look at your ACEs screen or your Pearl screen and you see that the score is 0, we will still provide education and anticipatory guidance on ACEs, toxic stress, and buffering factors. If the score is a 0 to 3 without any associated health conditions, you will provide education, anticipatory guidance. You'll talk about buffering factors. And if needed, you will make sure that you link the families to appropriate services and interventions, right? We also want to make sure that we are assessing for those protective factors, those resiliency factors, and really jointly formulate a treatment plan with the patient and family. A high risk score is a score of 1 to 3 with associated health conditions, or a score of 4 or more with or without associated health conditions. Our response is to provide education about toxic stress, to understand the role of toxic stress in the patient's health condition, to talk about buffering factors, to really support these protective and resiliency factors, and then again, jointly format a treatment plan that we can link the families to services and resources as needed, making sure that we follow up with families. Sometimes you might get a screen that is incomplete, so the score is unknown. If that happens, it's okay. What you want to do is to normalize the conversation, provide education on ACEs, toxic stress, and buffering, and suggest that the next time the family comes in for a well visit, that we can offer the screen again. We just referred to ACE-associated health conditions. What are those? ACE-associated health conditions are health conditions that have empiric evidence to show associations between ACE exposure and health outcome. There's a broad range of ACE-associated health conditions that include cardiovascular, pulmonary, immune, metabolic, mental health, and substance abuse conditions. And I do want to point out that the relationship between ACEs and mental health outcomes, such as depression, anxiety, is commonly recognized, but oftentimes we don't recognize the physical health manifestations of the accumulation of a dose-dependent relationship between ACEs and toxic stress. A recent meta-analysis demonstrated that the single greatest driver of ACE-associated costs in this country is actually cardiovascular disease. There is a consensus of scientific research that demonstrates that the accumulation of adversity, especially when experienced during sensitive and critical times of development, is the root cause of some of the most harmful and persistent expensive health challenges facing our country. And that ACEs are associated with 9 out of 10 of the leading causes of death in the United States, with heart disease and cancer being at the top. Other ACE-associated health conditions you'll see here. The Office of the Surgeon General really scoured the literature to pull together a list of these ACE-associated health conditions in both pediatric and the adult populations. When you look at this list, starting from the top, you'll see it starts with those physical health conditions. And then at the bottom, you'll see some of the behavioral and the mental health conditions. What this shows is the probability of having these health conditions or symptomatology based upon being exposed to ACEs. Within the pediatric field, we notice that some of those symptomatologies include being diagnosed with asthma or allergies, having frequent headaches, being obese or overweight, not being able to sleep well, having developmental delay, having depression, or even skipping school, having ADHD, having an early sexual debut. In the adult population, the physical health manifestations of the accumulation of ACEs include cardiovascular disease to diabetes to obesity and hepatitis to arthritis to depression, suicidal ideations and attempts, PTSD, alcohol use, or even teen pregnancy. As a provider, we have a big role to play in making sure that we can reduce exposure to ACEs and toxic stress in half by one generation. It is imperative that all of us as primary care providers learn the science and assess for toxic stress physiology and symptomatology. We have to stay rooted and grounded in trauma-informed care, help patients to understand the role of toxic stress in their health condition, and educate families about ways to regulate their stress response. We want to be able to support families in identifying strength and coping strategies, and then address health concerns and manage chronic illness. So our clinical response is multifactorial. Really understanding this idea of trauma-informed care. It means that we have to establish trust. We have to make ourselves trustworthy. We have to be able to provide safety and welcome patients, really focus on centering patient voice and collaboratively make decisions. We want to supplement our usual care for ACE-associated health conditions by providing patients education on toxic stress and really offering strategies to regulate that stress response. And these strategies are based upon 7 evidence-based stress interventions, which I'm going to cover soon. We want to be able to validate the strength and protective factors that families are already using and encouraging them to do that more. We have to think about our network of care, right? How are we referring families to both educational materials, but also to community-based organizations and resources such as local parks or other types of community health organizations like food banks. And then we follow up with our patients using the presence of ACE-associated conditions as an indicator for treatment. Is your asthma now better controlled? Was it initially very poorly controlled? As part of this randomized controlled trial that I had mentioned, where we wanted to create a prospective ACEs screening tool, we really wanted to look at the biomarkers and then think about interventions. We interviewed providers and we asked them, what do you want to say to families about ACEs? What do you want to say in terms of regulating the stress response and anticipatory guidance? We then compiled all those interviews and did thematic analysis. And based upon that thematic analysis, we came up with anticipatory guidance scripts. I love acronyms, and so we compiled those themes into this acronym note. We write a lot of notes as providers, and so it's easy to remember. So this is what you use when you're delivering your anticipatory guidance and education to families. You start with the N. The N is for noticing the relationship between the caregiver and the child, to notice the strengths and to call them out. So an example would be, I love it when little Susie wants to give you a hug. Every time you smile at Jose, he smiles back at you. It's wonderful to see how much little Luke is enjoying the fact that you're reading that book to him. Right? It's really important that if you have a teenager, that you keep open channels of communication and really lean into that relationship. O is for offering the science, and I usually always say the same thing. What I say is that stress affects our hearts, our minds, and our bodies. Stress can impact children, and it impacts adults. The T is for tools. We have tools and resources to support you. And the E is for empower. Some of the best conversations I've had as a pediatrician with my families is when I've walked in the room and I said, "You are a good parent. You're doing a good job. I am here for you, and you are a hero in the life of your child." So notice their relationship, offer the science, talk about tools, and empower the family. This notion of focusing on strengths and relationships is really supported by the Strengthening Families framework. And the Strengthening Families framework has 5 protective factors, right? And these are characteristics that help to protect families against risk factors for poor outcomes and really promote strong families and optimal development for children. Each of these protective factors summarizes tons of research that illustrates how each of these characteristics works in order to achieve a positive outcome that we want for all families. And so those 5 factors are making sure that the caregiver has support, that there are social connections and cohesions, that caregiver has knowledge of parenting and child development, that we're addressing unmet basic needs, and really focusing on the social, emotional resilience and wellness of children. These 5 protective factors are grounded within this framework of resiliency. And oftentimes people don't think that resiliency, just like toxic stress, is biologic. So I'm sharing a definition that I love of resiliency, which is that resiliency is the ability to withstand or recover from stressors and results from a combination of intrinsic factors and extrinsic factors, like safe, stable, nurturing relationships with families and caregivers, as well as predisposing biologic susceptibility. And of note, with scientific advances in the understanding of the impact of stress on our neuroendocrine, immune, and genetic regulatory health, we must also advance our understanding of resiliency as having neuroendocrine, immune, and genetic regulatory domains. Resiliency is about coming to homeostasis. There are evidence-based strategies that can help us to build our resiliency, to help us come back to homeostasis and really regulate the toxic stress response. These 7 strategies include exercising, right? And it doesn't have to be that you do 60 minutes all at once. It can mean that while you're doing dishes, you turn the music on, you dance around, you do the hula hoop, you do 35 jumping jacks, that you power walk around your block a couple times a day, that you do bedtime yoga or do 10 push-ups, that you play. The next is healthy sleep, and having a sleep routine is very, very important for helping your body stay regulated. We want to make sure that we have balanced nutrition, and this is not about losing weight or being on a diet, but it really is understanding that food itself can be medicinal, right? And that we want to get rid of this processed food, make sure we're focusing on fruits and vegetables and foods that are rich in omega-3s, including fish, nuts, and fiber. Supportive relationships we went over before, but maintaining healthy relationships, and whether that's virtually or in person with the folks that you live with, is really critical to our brain wiring. Practicing mindfulness can look like a lot of different things for people. It might be meditation or yoga or prayer. I want you to understand, though, that mindfulness itself can help to strengthen our brain pathways and help to buffer that stress response. Mental and behavioral health is critical. We have to engage in promoting our own mental health, and this might look like talking to a mentor or a loved one, talking to your doctor, or actually going to therapy or seeking psychiatric care. More and more literature is coming out about the access to nature, about how being inside helps to regulate blood pressure, how it brings our heart rate down, how it brings down our levels of cortisol. The other piece of the response beyond these 7 evidence-based strategies for stress regulation is really around creating these networks of care, these multidisciplinary teams that that can help us link families to resources. And some of those resources might be food resources, resources for housing, activities, helping families make sure the utilities are on. It might be medical legal concerns, help with childcare, more and more recently with distance learning, helping families get internet and devices. But it's about building out a network of care so that we can link families to resources and refer them. Another piece of the response is about primary care-based mental health interventions. Being seen and being heard is in itself therapeutic. Talking about anticipatory guidance to promote wellness is actually part of the treatment of regulating the toxic stress response. There are other types of innovative programming happening within primary care that include group visit models for resiliency, behavioral health integration, being able to link families to resources or psychiatry or community-based mental health resources. I think that we've all had a hard time getting through this pandemic as primary care physicians. And part of talking to families about ACEs is recognizing vicarious trauma, focusing on staff fortitude. Within our own clinic, we've had to focus on these principles of centering, connecting, and collaborating. The idea of centering is about how do we bring oneself, ourself, into balance? It's about listening to our internal cues, accepting what is true, being kind to ourselves, finding gratitude, and really developing self-awareness, self-regulation, self-empathy, self-trust, self-forgiveness. Connecting is a skill about building relationships and connecting with our families, being able to notice others, to do heartfelt listening as if your whole body is an ear, to choose kindness and to speak authentically. Collaborating is an experience of having a shared purpose and acting for a common good. As your entire clinic, department, your organization moves towards universal ACEs screening, it's going to require that everyone is on the same page and aligned and collaborating together. It's about noticing the group and appreciating that group. It's about seeking agreements and honoring them and being accountable and contributing intentionally to that group agreement. Sustainability is also critical when we think about implementing ACEs screening and response. And so when we think about sustainability, we want to think about how are we drawing down on payment for our clinics. ACEs screening is voluntary. And at this point, Medicaid providers within the state of California are eligible to be paid for screening if done within the periodicity recommended by the state, which is annually for 0 to 21 and between 21 to 64 once in the lifetime. As of July 1st, 2020, Medicaid providers have to self-attest to completing an ACEs training, and then they can receive payment for screening. So you can find the attestation form here on this link. And we're going to go through that, the way to attest in a little bit more detail on this slide. So DHCS requirements for payment include that providers take an online or core training prior to receiving payment for ACEs screens. Once you do that training, you attest, and then you can start to bill for screening. The payment rate is $29 per screen, and there are healthcare common procedural codes. Those codes, there are 2 of them. There's G9920, which is for an ACEs score that is low risk. That low risk is a 0 to 3. And there's G9919, which is an ACEs score of 4 or more, which is considered high risk. On the Pearl screen, These scores are for part 1 because, as we talked about, part 1 are those initial ACEs, those original ACEs in the 3 domains and 10 categories. Part 2 is not part of the billing code for screening. And so let's say, for instance, on part 1, the score was 2. On part 2, the score was 1. Your ACE score is based upon part 1, so it's a 2. In that case, you would bill it as a 9920. Qualifying ACEs screens are eligible for payment in any clinical setting in which billing occurs through Medi-Cal fee-for-service or to a network provider of a managed care plan. To receive payment through Medi-Cal managed care, the provider also needs to be a network provider of Medi-Cal managed care health plan billing for services provided to a member of that health plan. So, for instance, a certified nurse practitioner or nurse midwife or social worker or therapist or a physician can all get reimbursement for ACEs screening. There's a lot of questions that we get asked at ACEs Aware. I want to refer you to our frequently asked questions section, where you can find out more information about screening, training, billing, documentation, provider attestation, provider and stakeholder communications, as well as those clinical algorithms. For those of you that do medical education, you will know that there's a big move towards case-based learning. And so I want to walk you through 2 cases. These are cases of patients that I screened as my clinic was rolling towards universal screening as a standard of care. So the first case, it was a busy morning for me, and I had a 2-year-old who was coming in for a well check. The nurse handed the patient the Pearl screen. Patient completed it, handed it back to me, and the Pearl score on part 1 was a 1. Knowing the algorithm for how to score and how to respond to ACEs, I noticed that the score was a 1 and the child had no ACE-associated health conditions. So my job was to deliver anticipatory guidance about toxic stress, to talk about buffering, and if I felt it was necessary, to link the families to resources. So I walk into the room, I do the majority of my well check, and as I got to my assessment and plan and was delivering anticipatory guidance, I used this NOTE acronym, right? I talked about how I love the fact that Mom and Sally are reading a book and how Sally's looking at that book so intently. And the strength of the relationship that they're building, they can lean into in good times, and it will also be there for the bad times, the hard times. That we know that stress impacts Sally, it also impacts adults, that the best thing that the mom can do is to continue being that buffer for Sally, that we do have tools and resources. I talked about the 7 evidence-based strategies, really encouraging them to be able to get out in nature, to exercise, to make sure they're eating well. And I told the mom that she's doing an awesome job. She's a great parent. And when I said that, the mom actually looked at me and said, "Thank you so much. I am so glad that you asked me these questions about Sally, because if someone had asked my mom those questions, every single one would have been positive. I wish that my pediatrician had actually asked my mom, and I feel like I am a good mom because I see her score and I know what my score was, and that makes me feel resilient." That mom's conversation meant so much to me because I feel like even though we talk about screening in an unbiased fashion, I was like, well, the score is 1. And I didn't expect the mom to have such an important response to ACEs screening, but yet I went through my workflows and my algorithm, and it meant a ton to mom. And it really helped us as a provider and patient build trust and relationship. And the conversation itself was incredibly therapeutic for this mom. And I was really grateful that we had had it. The next case is a 5-year-old who came in for her school physical. And again, the nurse had given the mom the Pearl screen. The mom had filled it out and then given it back to me. And when I looked at the screen, I saw that the total score on Pearls was a 7. For part 1, it was a 4. For part 2, the score was a 3, which really put her at high risk, even without having an ACE-associated health condition. As I was delivering my anticipatory guidance, I used my NOTE acronym and I discussed the relationship. I discussed the science of toxic stress. I focused on the health impacts across the board, physical, emotional, and behavioral. I talked to the mom about tools and resources that we have that we could link her to, and really empowered that mom to say, you know, I understand there's a lot going on and you're doing a remarkable job. And this mom looked at me and she said, girlfriend, I got her. I got this. She said, I know we've had some rough times and we are connected to resources. She's getting some therapy through the school and we're good. We got this. I went through the 7 evidence-based strategies, including exercise and sleeping, balanced nutrition, supportive relationships, practicing mindfulness, and teaching her breathing, right? And so we went through this exercise, 4-1-5 breathing, where you put your feet on the ground, that you breathe in to the count of 4, you hold it, you breathe out to the count of 5. I encouraged this mom because she already was engaged in supporting her daughter's mental health. And we talked about going outside, going for walks, soaking in the sun, making sure she was wearing sunscreen. And the amazing part of this experience was that the mom knew there was a lot going on in this girl's life, right? The only person in the room that didn't know what was going on was me as the provider. And the mom knew what was going on. And this mom was a hero. And she was doing everything she can to pull resources together in order to support her and her family. And my job as the provider was to be in it with them. So my tips for all of you are that before your clinic starts, whether it's a morning clinic and you look at your notes the night before, or if it's an afternoon clinic, if you're looking at what patients are coming in that morning, be able to identify who is due for a Pearls or ACEs screening, right? So understanding the periodicity of who needs to get screened, that it's annually up to 21 and then once in a lifetime. During the day of clinic, just talk to your staff, let them know who you want to screen, and make sure they have access to the appropriate Pearls tool. Make sure that the staff can collect the tool from the family before you go in the room, and then review the screen prior to you entering the exam room. Remember your anticipatory guidance acronym. Make a plan that you co-create with the family about the 7 stress regulating techniques, as well as refer to resources and interventions. Make sure you're documenting what you do in the EMR, and then schedule follow-up. We have this opportunity to really support this big, bold vision that's being put out by the Office of Surgeon General to reduce exposure to ACEs and toxic stress in half by 1 generation. We have an opportunity to shift and transform our organizations, to have new payment systems. We have the ability to gather and share data that can create evidence-based policy. There's a ton of new research that is emerging. And sometimes I think the biggest challenge is to shift our own hearts and minds, right? To understand that the science of stress is universal and that trauma is ubiquitous. Our job as clinicians are to universally screen our patients, to have those hard conversations, to make sure that they're strength-based, and ultimately to improve outcomes for all of our children. This is my contact information. Please feel free to email me. And I thank you very much for your time and attention.